and I'll be your host for the weekend, so if you've got any problems, this is the face to contact. And on behalf of Sosposa, I would like to welcome each and every one of you. I really salute you for taking a day off work, losing income in this tight financial period, and sacrifice whatever to be here. This is really a great experience just to have people physically here again. As far as Sosposa is concerned, our main aim is to promote and advance the skills of sedation and to make this a safer practice and to advance it to all our colleagues that's interested in this field. So, but we need your help, and this is why we do things like this, not just for the CPD points, but to actually advance our skills and knowledge. So I'm delighted to say I'm part of a formidable group of experience as far as sedation is concerned. And I would like to introduce to you the Sosposa Exco. And as I mention the names, please stand up so that people can recognize you. We don't need to introduce Prof. James Rudolph, sir. He's our honorary president. Prof, please rise just for this occasion. We are privileged to have a father of sedation in the world, and we can call him Prof, our Prof. So, Prof, thanks for the calling that was on your life and that you are still pursuing it and giving us the opportunity to follow in your footsteps. It changed my life, and I think you've changed a lot of people's lives. So thank you. Our chairperson, Reinhard de Wet, myself at the moment is the deputy chair, so I like to think of myself as Reinhard's right hand, but it's nice to have a leader like Reinhard. Our treasurer, Peter Loots, rise and shine. So, those of you who still owe money, please speak to Peter. Peter Canellas. Right at the back. That's the secretary. So, while we've got Peter on the line, for those of you who haven't signed up as members yet and would like to join Sosposa, please speak to Peter. And if you don't get any of our communication or newsletters or whatever, he's the man to talk to. And if you've got any questions, you can ask Peter as well. He's my right-hand man, or go-to. Vickers Ninober. Alright. Vickers is our fundraiser and brand man, so please, if you have a few millions lying around that you would like to share, we'll take it gladly. And then we've also got Cherise Lapere, who's not here today. She just had a baby, so we've excused her from duties. And then, I'd like to think that each and every one of you sitting here is probably a candidate for the next Exco, to be part of the next Exco. It's time for some of us to pass the baton. And please, if you feel the calling, raise your hand. We really would be thrilled to have new blood on board. Like I said, the Sosposa membership, it's because of your membership that we can do what we do. Unfortunately, everything costs money these days, and to build a special interest group, a group like Sosposa, we need your participation. I've got some membership forms here, otherwise speak to Peter Canellas about it. We've got a Sosposa WhatsApp group as well, and the idea of the WhatsApp group is literally that you don't become isolated. So if you do have a challenging case or things that you're not sure of, or you just want to bounce something, ideas off, that's the place to go to. And like this week was, for those of you who's part of it, would know that, where's Mohammed Mullah? Pushed us out of our limits with what he's doing under sedation. And myself, I had a case yesterday of a 170 kilogram male that we had to do implants for. Is this possible? Can you do it? How do you handle it? If you have run into things like that, post it. We've got a lot of expertise that can advise us and and say yeah or no or help us. So don't become isolated, become part of the group. If you are not part of that group yet, please speak to Peter Canales. Then just a few admin things. You know where the toilets are. There is a program when we will have lunch and all these things, so please just attend to that. And then we will sign or send around a CPD form that you have to sign for every session. Unfortunately, if you haven't signed it, you will not get the CPD points. That's not my regulations, that's how CPD works. And then we also have a attendance or a feedback form that I would like you to send back to us. Again, we need this form before we can give you CPD points. So everybody was supposed to get it by email, and just send it back to Teresa, who's our secretary, doing the emails stuff as well. Right. Please support our exhibitors on the outside. It is really a struggle to get them here. The budgets are tight, so please support them. They support us, and it's because of them that we can do what we do. Alright. Then I've got a special need. I'm technologically disadvantaged, so we need people with skills, social media skills, especially somebody that can set up a Facebook page for us. And we want somebody from within our community to be part of it. So if you've got that calling, please let me know. We will gladly like to help you. And then just before we start, we always, I don't think we realize how privileged we are to do what we do and have what we have. Unfortunately, we've lost one of our colleagues this week, Cecilia Roberts, and we tend to think everything will be okay tomorrow again, but we might not be here tomorrow. So while you're here, I would like to challenge you. Make as much friends as possible, share your experiences, your expertise, and let's build this community, because we might not have it forever. So I want to salute Cecilia. She was a brilliant colleague and will surely be missed. And then it's my privilege to introduce the one and only Prof. James Rudolph, sir. Prof, thanks for always being available, and thanks that we can always just press your buttons.
Thank you, Louis, for your kind words. Welcome all. Nice to see you all. You know, it's indeed to be honored when people say it's a calling for your life, because it's indeed what it is for me. And people ask me sometimes, why are you still going on? I say, well, my calling is still there, I've got to go on. And it's not got to go, I enjoy every moment. I enjoy seeing people here that I haven't seen for a long time. I may come, I said to Chris just now, listen, I want to shake your hand the second time, but I know it's the second time, so it shows you I haven't got dementia. It's so great to see you all here. I'm going to start introducing the speakers to us. I want you to watch at your program. At your program you will see the T will be 10:30, not T 10:45. The idea of this whole seminar, let's call it that, is interaction. So if you're not going to interact and going to ask questions, if I give a lecture, I'm going to ask you to answer certain questions. So please let us stand together. I want to introduce to you first Marie Janssen van Rensburg. I've just been saying to her, I cannot help but telling you, I always say to people, the bird sings a song. It's not about the bird, it's about the song that you sing. And those are the people who have been singing the song of salvation. They've been working together, and she also did the diploma for 25 years, I think, Marie, that's where we're coming from. Thank you for your contribution. The other people here that are mentioned, Reina's name a little bit later, our experience in Kenya also. You remember the day you said, it is so hot that I'm sweating through my hair, can you remember that? Okay. So Marie obtained both her degrees, also an anesthesiologist at Bloemfontein University of Free State. What I'm writing is what they gave me. If I would have written this, I would be too late. I would have a lot more to say. 2002, she completed the postgraduate diploma in sedation, University of Stellenbosch. Since then, she's been involved really actively training sedation from the Aga Khan University in Nairobi to the University of Western Cape to the Free State. Full-time practice as an anesthesiologist in Paarl, but I also keep her full-time with academic work. So Marie, thank you so much. It's such a great pleasure to welcome you here.
Morning everybody, it's really wonderful to be back here. It's Stias, I can hardly believe that we're back, and it's a privilege to be here. My talk is on drug allergies and sedation, and I'm not sure I'm going to be done in 30 minutes, but I'll try. Okay, so as most sedation practitioners know, that one of the most important questions to ask One of the most important questions that you have to ask your patients before you start the sedation is whether they have any allergies for food, medications or plasters. It's not working anymore. No, it's not working. Okay, and then when you get answers like this, your heart just sinks. So the problem is you still have to figure out, are these true allergies? And if they are, what are you going to do about it? Now, if you have a sedation and the patient gets an anaphylaxis, the diagnosis may be very difficult. That is because the diagnosis of an anaphylaxis or allergic reaction is based on clinical symptoms and signs. And as you know, patients who come for sedation are usually fully clothed, so the skin signs may be obscured by the clothing and also by the surgical drapes. And things like itching and abdominal pain that may be part of a prodromal symptom complex may not be reported by a patient who is under sedation. Heart rate and blood pressure changes may be attributed to the physiological changes in response to surgery. So you have to have a high index of suspicion to make the diagnosis of an anaphylaxis or allergic reaction. It's very important also because, as you know, it may be fatal, so you have to diagnose and treat it promptly. And to complicate matters further, there's a spectrum of symptoms and almost anything is possible. You can have minor cutaneous symptoms like urticaria and itching. And it's interesting to know that about 70% of patients who have an immunoglobulin reaction do have cutaneous symptoms, and as many as 90% in non-IgE reactions. And only 10 to 20% of patients do not have any cutaneous symptoms at all. So you also have to then keep in mind that maybe if you think it's an allergic reaction and you look for skin signs and you don't see anything, that it shouldn't mislead you, that it can still be an allergic reaction. And as you know, the symptoms can be life-threatening with bronchospasm, vasodilatory shock, and pulmonary vascular injury. So there are factors that will increase the severity of your anaphylaxis, and the severity may increase with age, and that is probably just because of older people who have many underlying cardiac and respiratory diseases. Patients on beta blockers, ACE inhibitors, ARBs, SSRIs, and tricyclics may have a worse outcome. And then also the presentation. If patients present with a vascular collapse or respiratory arrest, they are inclined to have a more severe course of their reaction. The speed at which the whole situation goes will also give you an indication of how severe it is. And then patients with underlying systemic mastocytosis or an increase in baseline tryptase may have a more severe reaction. So when you do a sedation, especially in remote locations, you should have a treatment plan ready, and you have to implement it rapidly and timely. Remember that patients under sedation, and also under GA for that matter, may have an altered sympathogenic response to shock, so they may not respond like an awake patient would do. If you do a sedation for a patient under spinal or epidural, remember that they may be partially sympathectomized, and therefore that they may need larger doses of catecholamines to restore their cardiovascular function. So, depending on the severity of the case, some patients may need full cardiopulmonary resuscitative support, and don't forget to activate the medical services in case you have to transfer your patient to an ER or high care. Now, at this point, I just want to remind you of the sedation guidelines, that it says that a patient who is treated in a remote location should receive the same level of care as patients in hospital. So if you get an anaphylaxis in a remote location, the patient is supposed to get exactly the same treatment as they would in hospital. And then also you'll understand why the guidelines state that a sedation practitioner should always have a trained assistant ready to help you in case of situations like these. Okay, due to time constraints, I'm not going to go into the treatment. This is just from the Resuscitation Council of South Africa, and it's on their website. It's maybe a post that you can put up against your wall, so most people know what to do if you get into such a situation. So what is anaphylaxis? It's a sudden and unexpected systemic reaction, and it's in a patient who was previously sensitized to an allergen, and now with re-exposure to the same allergen, the body recognizes it as an invader or allergen, and then kicks off a chain reaction of symptoms. So the body produces antibodies specific to the drug or the allergen, and that binds then to the immunoglobulin E, and that binds to the surface of cells of mast cells and basophils, and preformed storage granules containing leukotrienes, prostaglandins, vasoactive mediators are then released. And that then leads to an immediate allergic reaction within minutes, or it can also be within hours. So the inflammatory substances are responsible for the symptom complex, with the respiratory system involved, sometimes with bronchospasm, upper airway edema, cardiovascular system with vasodilation, and you can have increased capillary permeability. And it's estimated that because of the increased capillary permeability, patients may lose as much as 35 to 50% of the intravascular volume in as little as 10 minutes. And I've mentioned the cutaneous systems involvement with urticaria. Stevens-Johnson and toxic epidermal necrolysis. I've just added this. This is the worst case of allergic reaction that you can get, and other organs may then be involved, and patients can get blisters with erosion of the surfaces of the eyes, the lips, the mouth, and the genital region. Okay, so just to complicate matters further, you can get a pseudo-allergy that is actually not IgE mediated, but you also get an immediate systemic reaction, and it then mimics an anaphylaxis. However, immunoglobulin is then not involved, but you still get the release of the mediators from the mast cells and the basophils. And that's then probably due to direct attack on the mast cells and the basophils. So that's, sometimes you see that with the reactions in radiology that you get after the dyes that they use, the flushing, the itching, and the hypertension. What is your chances of getting an allergic reaction? Well, we know that many medication can give adverse reactions, but only about 5 to 10% are due to true allergies. So you have to ask patients about previous and current drug use, and also if they had any previous adverse events to drugs. You may have to pay special attention to bracelets like the medic alert that will alert you in case the patient had a previous reaction. And remember that any drug actually has the potential to cause an allergy. Interestingly, if you have a family history of a drug reaction, doesn't necessarily mean that another member of that family will have a reaction to the same drug. Factors that may increase your risk of an allergic reaction is a history of a previous adverse reaction, so you do have to take that seriously if a patient tells you that. If you have a history of allergy to one drug, there is a chance that you can have another allergy to another drug. And then, logically, frequent drug exposure, the more drugs you use, the bigger is your chance to get an allergic reaction. Underlying disease, I've mentioned. And also, interestingly, apparently rubbing on skin more prone to give allergic reactions than intravenous use, and intravenous use more prone to allergic reactions than oral use. So when you see your patient before the sedation, you have to ask about any unexplained situations where they had severe hypertension, maybe bradycardia or cardiac arrest, if they maybe have unexplained bronchospasm reaction to drugs, and also widespread urticaria and angioedema. If a patient has a history of previous events, you should use the drugs with the lowest risk of allergy, use as few drugs as possible, and then avoid the drugs with a high potential for allergies, like your antibiotics. You must have a high index of suspicion, and you must be ready to treat, as I've said. So the drugs that are most often the culprits are the antibiotics like penicillins, neuromuscular blockers that we usually don't use in sedation, aspirin and nonsteroidals, and anticonvulsants, chemotherapy, and monoclonal antibody therapy that fortunately we also don't use in sedation. Okay, multi-drug intolerance is where patients are allergic to more than 3 drugs. It's more common in advanced age just because older people had more exposure to different drugs, so bigger chance of being allergic. Females, and then also patients with many different health conditions. Only a few of these are true allergies. If patients have so many allergies, you must try and avoid the ones that they're allergic to and just re-challenge as necessary. Remember that complementary and alternative medicines are often considered natural, and therefore it's considered to be safe, but natural isn't necessarily safe because these drugs are often not subjected to safety and efficacy testing like the other over-the-counter drugs and prescription drugs that we use. The ingredient list may also not be complete and it may be incorrect, so patients may actually also have allergic reactions to these so-called natural or safe drugs. As you know, during sedation, patients they can get many different drugs. We use many different drugs: sedatives, hypnotics, opioids, local anesthetics, and antibiotics. And as you know, many of the drugs that we use cause vasodilation and hypotension by themselves. So it may actually be difficult to distinguish the normal reaction of the drug from an anaphylaxis. If you use blood and blood products in your during your sedation, remember that they can also cause anaphylaxis and allergic reactions, and that's a so-called transfusion-related acute lung injury, where patients get dyspneic and hypoxic usually within 6 hours after the infusion. So let's look at some of the allergies that patients can have. Sometimes patients will tell you that they're allergic to eggs, soy and peanuts, and then that raises the question of whether you should be using propofol. The reason is that propofol is mixed in soybean oil and lecithin, so it is then thought that maybe because patients are allergic to peanuts, which is actually not a nut, but it's part of the soy family, so that the patient with a peanut allergy may actually react to the soybean oil in the propofol. But the truth is that soybean oil and lecithin are both fat substances, whereas people who are allergic to eggs and soy are allergic to the proteins in those substances. So it's not a fat allergy, but a protein allergy. So patients who are allergic to peanuts should not be allergic to soy, and therefore they should not react to the soybean oil in propofol. True propofol anaphylaxis have been described with hives and systemic reaction, but these were mostly in patients who were not allergic to eggs. So eggs also is safe to use, again, because it's not it's a protein allergy and not a fat allergy. Patients who have had an allergic reaction to propofol itself, the causes are unclear at this point. And just for completeness sake, I'm adding propofol frenzy. That is where patients get a neuroexcitation. So it's not an allergic reaction, but maybe if the patient presents with the propofol frenzy, you may think that they may actually have an allergic reaction. But it's more like an agitation with non-epileptic spells and agitation that you can get. Doctor, I'm allergic to morphine. We know that morphine causes a release of histamine from the skin mast cells, and that's usually not a true allergy, but more a pseudo-allergy. It can usually be mild and not life-threatening. And it's also interesting to know that it's the natural and semi-synthetic opioids that are more prone to allergic reactions than the synthetic ones. And you can treat it with histamine 1 receptor antihistamines. So the opioids, true allergies and anaphylaxis is rare. If you have a patient with a history of anaphylaxis to one of the opioids, you may not be sure which opioid you should use then, because there's always the consideration of possible cross-sensitivity. The risk, however, is probably low, and you can use antihistamine or glucocorticoid beforehand if you want to. A skin test is not practical because of the histamine release from the skin cells. Morphine is a naturally occurring opiate with definitely a histamine release. And as you know, with IV administration, it may cause vasodilation and also urticaria. I'm sure most of you have seen the little urticaria along the line of infusion in some patients. And it can also have other cardiovascular effects, like the vasodilation that we sometimes use it for to drop the blood pressure in patients. So it may actually be beneficial. If it is a problem, you can just treat it with IV volume administration and/or a dose of catecholamines. This is a very nice table that just shows the different classes, clinical classes that the opioids belong to. I think the pointer is not working. There it is. On the right-hand side, you can see that morphine belongs to the phenanthrines, like most of the others. So if you have a patient with a morphine allergy, you can maybe use something like L-fentanyl that belongs to a different class, or fentanyl, which is in the same class as L-fentanyl. So it's just a nice table to keep at hand if you want to decide which opioid you can use. Local analgesics, true allergies are very rare, and anaphylaxis even more so, especially if you're going to use preservative-free local anesthetics. Often the apparent allergic reactions that patients have to local anesthetics are actually not anaphylactic reactions. but more like a reaction under their situation, like a vasovagal reaction, anxiety, or maybe other agents that are involved, like latex or antibiotics. Sometimes also if you use epinephrine with your local anesthetic, some of the epinephrine may end up intravascularly and the patient may experience agitation or flushing because of the epinephrine and not because of the local anesthetic. You can do skin testing or test those if you want to. Aspirin and non-steroidals can cause hives, itching, swelling, shortness of breath, nasal congestion, wheezing, and even fainting. Remember that patients who are allergic to aspirin may also be sensitive to non-steroidals. The diagnosis is clinical, and there are no skin and blood tests available. Treatment is avoidance. Okay, others, thiopentone may cause some histamine release. Fortunately, we don't really use that anymore. Etomidate and ketamine to a lesser extent, and allergic reaction to benzodiazepines are extremely rare, so that's not one we have to worry too much about. Doctor, I'm allergic to penicillin. Well, penicillin and cephalosporins are from the same group of beta-lactam antibiotics, and many patients are diagnosed as children as having a penicillin allergy. But sometimes maybe they had a viral infection and then they get an antibiotic for the viral infection. Then they develop a rash as part of the viral infections and then they are incorrectly diagnosed with a so-called penicillin allergy. So as many as 90% of patients who have a tag of penicillin allergy are not truly allergic to penicillin. And of those who are truly allergic, about 50% lose the tendency within 5 years. So just remember that just because the patient thinks they are allergic to penicillin doesn't say they truly are. Now, withholding a beta-lactam antibiotic because of the penicillin allergy tag that a patient has may not be in the patient's best interest, because a patient with a penicillin allergy tag is unlikely to get a cefazolin pre-operatively. So sometimes alternative broad-spectrum antibiotics is then used instead of the penicillin, and these may be less effective. They are sometimes more costly. They may actually increase the antibiotic resistance, and even the risk for surgical site infection may be increased. So it is important to try to determine whether the patient is truly allergic to penicillin. So how are we going to do that? Well, if you have time, you can refer the patient to an immunologist or allergist, or otherwise you can just do a good history, ask about the reaction that the patient had. If it's kind of vague, doesn't really sound like an allergy, you can do a test dose. If the test dose is negative, you can give the full dose, and if the patient tolerates the full dose, there's a very small chance that they're truly allergic to penicillin. If the test dose is positive, you can do a skin test or intradermal test, or just use alternatives. Okay, so the so-called test dose or graded challenge is where they give small doses initially, and then every hour you increase the dose. Start with small dose, and then in an hour give a bigger dose, and so on. I think with sedation we don't have the time to do that, so it's probably not practical for us to do that. The rationale is that the idea is that if you give a small dose, it may not be enough to trigger an anaphylaxis, so that the patient may have a reaction but not a life-threatening reaction, and then you can just withhold the rest of the dose, and thereby preventing a worse reaction. But those who claim that it's not a good idea is that the threshold for the reaction is unpredictable. So a small dose may be insufficient in some patients to cause an allergic reaction, whereas in other patients it may actually be sufficient to cause an anaphylaxis anyway. You can also do unintended harm with your test dose by delaying the procedure because you're still doing your test dose and the case has to start, or you may delay the antibiotic administration, so there's then not enough time between the antibiotic administration and the start of surgery, or you may just forget to give the rest of the dose, which may not be in the patient's best interest anyway. There's also not enough evidence about this, but if you want to do this, you can maybe just give a small dose 5 to 10 minutes before surgery, and then if nothing happens, you can give the rest directly before surgery. So back at the history, is it a true allergy? If you ask the patient, and now this time maybe they give you a history of hives, itching, swelling, and telling you that they had some swelling of the upper airway, you may think that maybe it is a true allergy, and that is a very reliable method to do a skin test in these patients to determine whether IgE was actually involved in the reaction. You can follow the skin test up with the intradermal test. If these are negative, it's very unlikely that the patient is truly allergic, and you can still do a test dose if you want to. Okay, so if it's positive, let's just use a different antibiotic, and remember that you then have to avoid all the drugs in the penicillin family. Cephalosporins is a close relative of penicillin. It has a beta-lactam ring structure and also shares R group side chain with penicillin. So there is the potential for immunoglobulin-mediated cross-reactivity. It's important to know that the immunoglobulin is actually directed at the R group side chain and not at the beta-lactam ring. So the chance for cross-reactivity is probably less than 5%. Even in patients with a true penicillin allergy, they should tolerate the cephalosporins. Prednisone specifically is a first-generation cephalosporin. It is widely used as a first-line prophylaxis. It has no shared side chain with penicillin, so there's a very low chance of cross-reaction, and it is safe to use in patients with penicillin allergy. Vancomycin can cause reactions that look like anaphylactic reactions, but it's very rarely IgE mediated, and it's usually just non-IgE mediated histamine release. So up to 50% of patients can get these cutaneous erythema, flushing, and pruritus, and it's known as red man syndrome. And it's very easy to prevent just by giving your vancomycin through a very slow infusion, maybe over an hour or so. You can also use antihistamines beforehand. Other antibiotics, there may be cross-reactivity between penicillin and carbapenems, but it's low, and any IgE-mediated reactions towards non-beta-lactam antibiotics is even less common. Quinolones I've added just because the increase in use, and with the increase in use, there's also an increase in mediated reactions. Some patients may have, about 2% of patients may have a delayed cutaneous rash after quinolone administration. Okay, strange as it may seem, patients can be allergic to cortisone. Most common, it's an allergic reaction like a contact dermatitis after topical application. So it's very rarely a true immediate allergic reaction. And if it is an allergic reaction, it's mostly after intravenous methylprednisolone and hydrocortisone. And then sometimes they also think that it's rather the preservatives and the diluents in the cortisone than the cortisone itself. Okay, I'm allergic to radio contrast. Well, reactions to radio contrast is not uncommon. Patients may experience anything from arrhythmias, vasovagal reactions, and flushing. These are not true allergic reactions, and IgE is very seldom involved. So it's more like a pseudo-allergy, and it's probably due to the contrast molecule and not the free iodine. Risk factors are the strongest prediction for a reaction to radio contrast is a previous reaction, and patients with a history of ATP, asthma, and food allergies also have a bigger chance of reactions. Female and beta blocker exposure may increase your risk for a reaction. So if a patient gives a history of previous reaction, you should consider whether the study is really essential, and is it essential to use contrast, or can you maybe do it without it? Does the patient understand the risk? And you can do proper hydration beforehand and use non-ionic isoosmolar radio contrast. Doctor, I'm allergic to sulfurs, and that can be very unnerving. If you look in your bag and you see that morphine's got some sulfate in it, atropine as well as magnesium. So what should you do now? Well, the truth is that most patients who are allergic, has a so-called sulfur allergy, are allergic to the antibiotic group containing sulfonamides. And there are actually two groups of sulfonamides. There are the aromatic amines, that is the sulfonamide antibiotics, and the non-aromatic amines, that is part of the sulfonamide non-antibiotics. And your concern for cross-reaction is then between maybe will the patient react between these two groups. But the good news is that the aromatic amine is probably the culprit that causes the allergic reaction. So the non-aromatic amines include drugs like some diabetes medications, glimepiride, many of the non-steroidals that we use in sedation like celecoxib, are part of the non-aromatic amines, and also some of the diuretics like furosemide. So these do not contain an aromatic amine, and there should be no cross-reactivity. So these are safe to use in patients with a history of sulfur allergy. I've added HIV and AIDS just because these patients are prone to reactions to many different drugs. It's probably part of the immunodeficiency problem. And they actually have the greatest risk of reaction to sulfonamide drugs. They can have a general maculopapular rash associated with fevers, and it usually develops after the first 2 weeks of treatment. So they have developed drug desensitization protocols because these patients often need sulfamethoxazole and trimethoprim as part of their treatment in HIV infections. So they do these drug desensitization protocols where patients are desensitized towards the drugs and can be treated successfully. Doctor, I'm allergic to seafood. Well, patients are often told that they're allergic to iodine when they are allergic to seafood, and that they should therefore avoid contrast radiological exams. This, however, is not true. Patients who are allergic to seafood are allergic to the proteins in the fish and the shellfish, and it has nothing to do with iodine, so there is no contraindication for contrast media in patients who are allergic to seafood. I'm allergic to iodine. This is an interesting one because iodine is in seafood, yogurt, bread, milk. As you know, iodized salt contains iodine, and iodine is a very important part of the basic human functions. So it's very unlikely that the patient will have an immune response to iodine. If a patient does get a reaction to contrast, it's probably not due to the iodine, because it's not consistent with the true IgE reaction, and it probably has more to do with the high osmolarity of the agents that they use. So it's probably rather a direct stimulation of the mast cells and the basophils rather than an IgE generated one. Remember that patients can have a delayed reaction after contrast with similar but milder symptoms that can happen some days even later after the contrast. So patients with a label of iodine allergy have a problem because patients then may not receive the life-saving radiological procedures that they need just because they have this iodine allergy. But there's no reason to avoid contrast media in patients with allergies for both seafood or iodine. There is, however, something like iodide mumps or iodism. It's not an allergic reaction, but it's actually sublingual, submandibular, and parotid swelling of the salivary glands, and that sometimes happens after contrast, and it's more an overload of iodide because of a decrease in the excretion of the contrast after the radiological examination. The treatment is empirical with steroids, antihistamine, and non-steroidals. What about iodine in antiseptics? We get it in betadine and povidone, and these patients often react with a contact dermatitis or irritant contact dermatitis, and that's also probably more a skin irritation than a true allergy, and also doesn't have any relevance to the contrast. Chlorhexidine is used very often, and with the increase in use, there's also an increase in so-called allergic reactions. The other problem is that it's often hidden in other products like lubricating gel, skin cleansing, and antibacterial wipes. And the risk is increased because of the unclear labels. They use these CHG or CHX, and nobody knows what it stands for, but it's actually CHG is for chlorhexidine gluconate and CHX for chlorhexidine. Just so you know that there is actually chlorhexidine in the cleansing or the lubricating gel that you use. I've just added insulin. Nowadays, very rarely we have any allergic reactions just because it's much more safer. In the older days with the protein containing insulin, there was a 50 to 50% increase in risk, and the mechanism is not entirely clear. How are we going to minimize our risk? Well, we can do it with a very good pre-op history. We must ask about previous events, and then try to prevent accidental re-exposure. Prophylactic antihistamines and steroids, some claim it does have no role, and only after anaphylaxis, but as I've said, you can try it if you want to. And then if you have maybe an antibiotic that you're not sure of, you can also always do your test dose for any specific drugs that you want to ascertain whether it is a true allergy or not. Thank you. 34 minutes.
Thank you very much, Marie. Are there any questions? Otherwise, I'm going to ask you questions. Any questions? Yes, Ilse,
Okay,
please.
I just wanted to say something which you didn't mention, is that in the Eastern Cape we've got quite a little, okay, in the Eastern Cape we've, hello?
Yeah, after.
Okay, so in the Eastern Cape we've got quite a lot of porphyria. Hi, hello?
Thank you.
Hello? Okay, I'm just going to talk a little bit louder. Okay, so in the Eastern Cape we've got quite a lot of porphyria. I didn't even know it existed, but I had quite a few patients, and you said that the benzos are very safe and you don't see allergic reactions. I've had quite a few patients who received the benzoadomicum 7.5 milligram tablet and just reacted funny. They had all types of pains and things and started vomiting, and you didn't know what was going on. It usually doesn't happen on the same day. It will be like a delayed reaction. And the only way we could adhere it to was due to the reason that they had porphyria. So I always say that porphyria is still with us. And in any porphyria patients, I avoid any benzos because they just get funny reactions. I don't know if anybody else knows about
I
this.
find it very interesting because as far as I know, midazolam is safe.
It's supposed to be safe for porphyria
So maybe
patients.
you must write it up.
But as I say, all the patients that I had, like the one guy got completely the others they got crazy, and it lasted for 2 or 3 or 4 days, you know. And he didn't know he was doing funny or weird things. The other patient vomited like, and all of them were known porphyrics. Okay, so that's why I'm a little bit hesitant over that. And the second thing I just wanted to know, especially on an easy question to ask is that if a patient tells you they're allergic, I just ask, have you ever been admitted to hospital? Because that cuts out about 90% of the true allergies. And the final thing is concerning local anesthetics. I had a patient not long ago who said to me that she's allergic to lignocaine, and I said, okay. She was in hospital, it was post-episiotomy, she collapsed, and it happened again after a few years. So they said to her, she's not even allowed to test for lignocaine allergy because they said it's crazy, she's going to die. So I said, any dental work previously? And she said that everything was done in theatre without local. And now she appears for a sedation for surgical removal of teeth. Now you're going to fix that. I can't do it without local anesthetic. So a test dose of articaine, and I must say, if you're allergic to lignocaine, articaine is the option.
Thank you, Ilse.
Anybody there at the back, John?
I would just like, if you could just tell us more about the propofol excitation.
I have to admit now that somehow Louis got the wrong PPT up here, because I was spending some time last night to put that the article on for you, and now it wasn't on here, so I think we've got the wrong one here, but I've got it, so I can give it to you. It was actually just recently that I read about it, and it's definitely not an allergic reaction, but post-operatively they get this agitation, and it has been ascribed to the propofol. But just ask me, I can give it to you afterwards. I have a question for you, if you don't have any questions. Why do you think females are more at risk for more severe reactions and a bigger chance of having anaphylactic reactions? You know? Yes.
Yes, thank you.
Yeah, so Maury, it's because of vanity.
Oh. You want to be in the limelight.
Agents that are used are quaternary amines, and there's a cross reaction with quaternary amines and muscle relaxants in particular. And in the Scandinavian countries, there's a huge increase in particularly women who've used cosmetics and anaphylaxis is the one thing. And the other thing is that there's a drug called Folcadine as well that they use, which has nothing to do with females, but it's just an interesting thing. I mean, Sweden and Finland share a border. Folcadine, I can't remember which country, but Folcadine is licensed in the one, but not licensed in the other. And the incidence of anaphylaxis is much higher in those with Folcadine as well. So cosmetics with quaternary amines and the Folcadine with the quaternary amines.
Okay, I just also read another article. Thank you for that. Nice to have clever people here. Another article where they did some tests in mice, and the female mice, whatever you call them, also had more severe reactions, and they found that it's because of the estrogen that actually promotes nitric oxide synthase. You get a bigger reaction of nitric oxide after the reaction, and that of course causes more vasodilation and capillary permeability. But that was in mice, so I'm not sure whether it's the same in humans.
I suppose if the mice wear lipstick.
Not yet. My house.
I just wanted to ask a question, especially for the group. I experienced that when I use, or the dentist or whoever uses Augmentin as antibiotics, apparently the sedation that I do don't agree with Augmentin. The patients get severely nauseous, they vomit for days on end. The moment you stop the Augmentin, because say for instance it's wisdom teeth removal, they get Augmentin to take out. The moment they start taking the Augmentin, they start vomiting, and the moment they stop the Augmentin, the vomiting stops. So I've got a rule now, sedation, no Augmentin, just plain penicillin. Anybody else with that? They love to give Augmentin post-op if they do.
Yes, please.
Prof, the one thing that I found, I gave a patient having a dental procedure a test dose of Augmentin because it was requested by the prosthodontist, and the patient ended up having a full-blown anaphylactic reaction in the chair. But how it started was she ended up with bronchospasm. It's very difficult to get in and listen to a patient's chest when they're fully draped and they've got everything around them. and being an adult onset asthmatic, I can tell you, bronchospasm starts as coughing. And it's very difficult to diagnose bronchospasm in a sedated patient when they're being operated on. If they start coughing for whatever reason, I mean, the first thing I thought was water going back down the back of the throat. They cough and they don't stop. So for early signs of onset of bronchospasm, you cough.
Thank you very much. I think we've got to move on. I just want to say a few words. Adverse events like what Mary was talking about now is a very relevant thing at international level. Do yourself a favor and go and look at the troops classification. If you don't know where to find it, just look at the SALSA guidelines. It's right at the back at the reference adult guidelines, troops classification, who give a classification of adverse events and what you should do. Now, Charles Coates wrote a beautiful article on adverse events. Well, it was just a small part of it where he said something very important. He said, when they get adverse events, they ask the people to write it down, the adverse event. And at the end of the month, they get together, like we talk about adverse events, they get together and they discuss the reason for that and how they are going to treat that sort of problem. I'm not going to say any more, otherwise we are late. I just wanted to give you that information. Thank you very much for the excellent lecture as usual. I have the privilege to Nadia come up now. I want to introduce you. Nadia, I'll just tell you now what she read about herself. Nadia has joined our sedation team at Wimbledon. She's from Wimbledon and joined Professor Diederik herself in training, postgraduate training. And this year we had 23.
Yes.
And 3 anesthetists, two physicians,
Yes, gastroenterologist.
and a gastroenterologist. Don't you think it's a good person to have a course like this, a gastroenterologist? So, Nadia is a superb organizer. You just got to stay out of the way, otherwise you get work to do. In any case, Nadia, what a pleasure to have you here in Pilsen. It's for us a privilege. I just want to say something about her. And Nadia, I'm not going to tell you all of these things. I've already said that you are a superb person and a supporter of sedation. She is an anesthesiologist. She's working in Brooklyn. I love what she's saying here. She has been involved with the sedation and anesthesia short course presented by the University of Free State since 2021. I want to tell you something that you don't know. This is the only accredited postgraduate sedation course in South Africa. This is the only one. You won't find it in the United Kingdom. But what I want to tell you is, you remember, well, maybe you don't remember, when we started the sedation here about 25 years ago, some anesthetists were a little bit antagonistic. They said, well, you're going to kill the patients with this sort of thing where they're awake and you do operations. And we just carried on with it. Now the Department of Anesthesiology, of which Edward Turk, a superb man, and Johan Diederik, a superb man, is the head of the department, is the only department of anesthesia in this country and the only one in the United Kingdom. So we are the only one department, and Nadia is part of that. Nadia, she's currently also doing a postgraduate diploma in interdisciplinary pain management through the University of Cape Town. So Nadia is going to talk about dexmedetomidine, the sedation practice. This is a prominent drug for all of us. So thank you for coming to Bloemfontein and say hello to them when you get back.
Thank you.
Good morning, everyone. I didn't expect an introduction like that. Thank you, Prof. And I'm very privileged to come from the University of the Free State in Bloemfontein, and I'm very happy to be there. So welcome, everyone. I hope you enjoy the 2 days here. I'm Nari du Plessis. Like Prof said, I am a consultant anaesthetist in Bloemfontein. Yes, my talk will be on dexmedetomidine, specifically the advantages and disadvantages in procedural sedation. So before we talk about advantages or disadvantages of any specific agent, we first need to look at what the ideal sedation agent is. So the American College of Emergency Physicians has got this comment that procedural sedation and analgesia refers to the technique of administering sedatives or dissociative agents with or without analgesics to induce an altered state of consciousness that allows the patient to tolerate painful or unpleasant procedures while preserving the cardiorespiratory function. So looking at the ideal sedation agent, first of all it needs to be predictable in terms of the dose response, and in terms of drug interactions you need to know how it's going to act or react with certain other drugs as well. We want an ideal sedation agent to have a rapid onset of action, but also a rapid recovery after administration, and then also an adequate duration of action, specifically if given as a single dose and not necessarily as an infusion. And then we want them to have minimal side effects, especially referring back to preserving your cardiorespiratory function. We want them to have an analgesic property, amnesic properties, but most of all be safe. So looking at dexmedetomidine, it's really nice because it has the effect of sedation, anxiolysis, it's got analgesic properties and also sympatholytic properties. So it's an imidazole-derived drug. It's a selective alpha-2 receptor agonist, and it's more selective to the alpha-2 receptors than the alpha-1 receptors, to a ratio of 1 to 1,620. It's also 4 times more potent than clonidine, which is the older brother of dexmedetomidine. So it causes alpha-2 stimulation in the locus coeruleus and the dorsal horn of the spinal cord, with inhibitions of substance B and decreased noradrenaline release. The important thing about dexmedetomidine as a sedative agent is that it doesn't cause the sedation by means of GABA mediation. So alpha-2 receptors are subdivided into alpha-2A, B, and C. So the effects you will see from the dexmedetomidine will be because of the effects on these specific subtypes of the alpha-2 receptors. So your sedation and hypnosis is because of the effect it has on the alpha-2A receptors. So this is on the noradrenergic neurons in the locus coeruleus. Your central sympatholysis will cause the lowered blood pressure and heart rate. And then it's got the central analgesic properties, or the analgesic effect centrally because of the alpha-2A receptors, and the neuroprotection and inhibition of insulin release. Secretion is also there. With the alpha-2B receptors, this is where you have your analgesic effects at the spinal cord level, and also the vasoconstriction from the peripheral arteries. And it also suppresses the shivering. And then with your alpha-2 receptors, this is where you have regulation of adrenaline outflow from the adrenal medulla and modulation of cognition, sensory processing, and mood. So looking at a bit of pharmacokinetics of dexmedetomidine, so we can administer it intravenously, nasally, intramuscularly, and orally, and use it as well as an adjunct in your axial techniques or anesthetics and peripheral nerve blocks. So in terms of bioavailability, if you administer it orally, it's got a very low bioavailability, and this is because of a very high first-pass metabolism. So preferably you don't want to give it orally, but rather intravenously and intranasally is also really effective. So it crosses both the blood-brain barrier and the blood-placental barrier. It's 94% protein bound, specifically to albumin, and it's got a volume of distribution of 1 to 2 liters per kg, and a context-sensitive half-time of 1 to 4 hours, which means whether you're giving it as a short duration of an infusion or even for longer, it's going to have a 1 to 4 hour context-sensitive half-time, so you'll have complete offset of the effects in that time period. It's metabolized by the liver, specifically with your cytochrome P450 enzymes, into inactive metabolites that's then excreted renally. Just a note on obesity. When you have a patient that's obese, rather use the lean body weight, not the actual body weight of the patient. Otherwise, you overdose the patients when you use their actual body weight because of these kinetics. So looking at the advantages and disadvantages, I'm going to divide it into the specific areas of the effect. So firstly, the sedative effects. The advantages is that it gives you a cooperative or an arousable sedation. There is easy transition from a sleep state to a wakeful state back to a sleep state when you arouse them. They say the physiology or the pharmacology is similar to the natural sleep physiology. So your memory and cognitive functions are not impaired, and there's a decreased incidence of delirium when using dexmedetomidine compared to other sedative agents. You also have a decreased requirement in any other anesthetic agents, whether it's inhalation or intravenous, and it's neuroprotective that it decreases the intracranial pressure and also decreases the cerebral blood flow and cerebral metabolic rate. The disadvantages is that dose dependently you can actually cause a very deep sedation or general anesthesia. The advantages of the analgesic effects, or one of the major advantages of dexmedetomidine, is that it's got analgesic effects where other sedative agents does not necessarily have that. So it gives you both spinal and supraspinal and peripheral mechanisms to your analgesia. It's antinociceptive effects on both somatic and visceral pain. And obviously it also decreases your opioid requirements during sedation then. It's also effective in prevention of neuropathic pain. The disadvantage, which is not really a disadvantage but just a limitation, is that this has got a ceiling effect at a dose of more than 0.5 micrograms per kilogram. So cardiovascularly is one of the areas with, I would say, the most disadvantages, if you want to call them that, or side effects. So the advantage is that it blunts the sympathetic response, it reduces myocardial oxygen consumption, and then the disadvantages, importantly, is dose and rate dependent on how you administer your dexmedetomidine. So initially you'll have a transient increase in your blood pressure, and this is because of the peripheral alpha-2b stimulation, which causes vasoconstriction. You will also have a decrease in your heart rate, which can be due to a reflex to the increased blood pressure. It's also dose dependent, and then you've also got the decreased sympathetic tone and enhanced basal activity, which will cause a decrease in your heart rate. And then your central alpha-2a stimulation will cause vasodilatation, which will then lead to a decreased blood pressure. You can also have cardiac conduction disorders, and like I said, this is dose and rate dependent. So dependent on the dose you administer, as well as the rate at which, or the duration that you administer your loading dose, for example, these will be more or less pronounced. So if you give a lower dose over a longer period of time, this will be less pronounced. So that major advantage, I think, that we all know of dexmedetomidine is that it's got very minimal respiratory depression. You maintain your minute ventilation. You do have a mild decrease in your tidal volume and a mild increase in your respiratory rate, but you still maintain your minute ventilation. You've got maintained airway muscle tone and airway reflexes, and it minimally affects the hypercapnic drive. It's also an anti-sialagogue, which is really nice, specifically to use dexmedetomidine with airway instrumentation like awake fiber optic intubations. The disadvantage then is your patient complaining of a dry mouth. Other effects, it's a decongestion. It can cause a hyperthermia, which will be just one of those things like, is my patient having a high temperature because of this or because of an infection or something, so that can be a disadvantage. It decreases gastrointestinal motility. There's a theoretical risk of adrenal suppression, and then a rebound effect with acute withdrawal of an infusion, but this is after a prolonged infusion, where they'll have the hypertension, tachycardia, and agitation, which is the opposite of what you had while you administered the dexmedetomidine. So just comparing dexmedetomidine to some other agents we use for sedation, this is just a few of many which compares dexmedetomidine to midazolam and propofol or propofol. So just to summarize it in a table, from these studies, the sedation levels across all three sedation agents were the same. They were appropriate for what procedures they were doing. They never really went overly into a deep level of sedation. With dexmedetomidine specifically, you have a decrease in your opioid consumption because it's got the analgesic properties. Cardiovascular effects, so from these studies that I showed before, the most effects cardiovascularly was in the dexmedetomidine group compared to midazolam and propofol. Propofol also had it, but not, it actually had it to a greater extent than the dexmedetomidine. Your respiratory effects, so with dexmedetomidine, like we mentioned, most of your airway reflexes and respiratory drive was maintained. And in the midazolam groups, there were desaturations, episodes of hyperventilation and apnea. And with propofol, it was also maintained, but to a lesser degree than with dexmedetomidine. With recovery time, it's a bit longer than propofol. We all know propofol's got a really short offset time, but I mean, that's not necessarily something that would make you avoid using dexmedetomidine. And then there was no mention of, or not a mention, there was no reports of nausea and vomiting in the dexmedetomidine and propofol groups, but patients that received midazolam did complain of nausea and vomiting afterwards. So with regards to patient satisfaction, propofol and midazolam was superior, but no one really said that midazolam was bad, that they had a bad experience with midazolam. And then with clinician satisfaction, midazolam and propofol, and I think this is because a lot of people have got a lot of experience with using midazolam and propofol as sedative agents. They were neutral in their clinician satisfaction, but they reported improved satisfaction for doing the procedures and having adequate sedation for the procedures with dexmedetomidine. So I think the main thing here is just you need to select your patients, you need to have specific indications for using specific sedative agents for whatever procedure you are doing. And I also always say that you need to know what procedure you're doing and whether it's going to be very stimulating and painful or not. And depending on that, you also decide on which sedative agent you're going to choose, and you need to add an analgesic. Even with dexmedetomidine with the analgesic properties, it doesn't mean you should not give anything else for analgesia. Topicalization or local anesthetic really takes you far. So just an interesting thing, these two articles I found really interesting because also dexmedetomidine is really safe, it protects the airway, you don't have respiratory depression, and these two specifically looked at the effects of dexmedetomidine and propofol on the airway, and they actually found that it's got similar effects, and not just similar effects, but to a similar extent, the dexmedetomidine compared to propofol, where it decreases your central ventilatory drive, so it makes you less sensitive to hypoxia and hypercapnia, and also it causes some decrease in muscular tone. I think it's just the rousability that makes it safer, or that we think it makes it more safer in using it to protect the airway and respiratory drive. So just some examples of where you can use dexmedetomidine in sedation. So it initially started with ICU ventilated patients. So the patients were really relaxed. The endotracheal tube didn't irritate them as much. They weren't deeply sedated for them not to feel uncomfortable from the endotracheal tube and being ventilated. And they could also be safely extubated on the dexmedetomidine infusion because of the respiratory or the minimal respiratory effects. So you can also use it as a sedative pre-medication before patients are coming for procedures. Once again, you can use it as an adjunct in either regional anesthetic techniques, or it will decrease your opioid requirements. So it's an opioid sparing agent, and it potentiates any other additional anesthetic agents or sedative agents that you give with it. It provides post-operative analgesia because of that analgesic effects. Neuroprotection in neuroanesthesia, like I mentioned. And then sedation for very invasive procedures, specifically looking at the airway, like awake fiber optic intubation, gastroscopies like endoscopies and so on. Patients with awake craniotomy, where you've got the analgesic properties, which also have the protection of the airway. They're rousable, so if you want to do neuro testing while they're doing the craniotomy, this is very useful. And carotid endarterectomies. You can also use it as a sedative agent in difficult patients, specifically like we mentioned now the airway, and in pediatrics, because children can sometimes experience a paradoxical reaction to midazolam sedation. So instead of being sedated, they're actually very hyperactive and not cooperative, and specifically children with behavioral disorders. And then sedation for radiological procedures. So we use dexmedetomidine where I work for our MRI sedations routinely, and it works really, really well. Yes, thank you. Any questions?
Thank you very much, Maria. Any questions? Anybody? Yes, we've got a lot of questions. Can we start with this?
Thank you very much, Dr. Sisi, for a great compliment to speak with you. Have you had any experience in combining dexmedetomidine with heavy marking in spinal anesthesia for procedures requiring spinal power?
Yeah, so I've used it in patients receiving spinal anesthesia or epidural anesthesia as basically the sole analgesic or anesthetic analgesic agent with the sedation of dexmedetomidine. So once again over there you've got your spinal anesthetic or your epidural anesthetic as the main surgical anesthesia. So you're not going to give the dose, your normal loading dose like you would with using dexmedetomidine as a sole agent. So you would give a smaller bolus dose just to reach a certain concentration and then have an infusion running. And once again, like I mentioned, because I think your question is about the hypertension and the sympatholysis, whether you're going to struggle with low blood pressures and heart rate and so on. So it's all dose dependent, so you give it a smaller dose over a longer period of time, and then you might still see it, but less so than when giving your normal 1 microgram
I
dose.
was actually, referring to using it intrathecally.
Intrathecally, I haven't used it intrathecally. I don't know if someone else has, but I haven't used
I
it.
have.
Okay.
Depending on the body
Yeah.
weight, between 5 and 8 mites,
Yeah.
combined with a heavy marking. And I find that it prolongs the duration of the spine. So all my hip replacements, knee
Yes.
replacements I've done with dexmedetomidine combined with heavy marking. And the remainder, I'm only using 1 to 2 mils, I use for my sedation
Yes.
intraoperatively.
Yeah.
So it works very well.
Yeah, I've never used it, but it sounds great.
Great. Could you, I'm going to give you Peter. Okay. Please.
Hi, Nadia. Thank you very much for a most informative talk and concise chat on dexmedetomidine. My question to you is, have you had to sedate a patient on the regular, very short intervals, and use dexmedetomidine? And have you found tolerance to the drug itself, that you needed to maybe adjust your dose accordingly?
So the ones I've used it for, the shortest procedures I've used it for is for MRIs, and then usually we use it for other, so just a little, I work in a hospital setting. I know a lot of other sedationists work out of hospital, so I use it a lot in theatre as a sedative agent in addition to something else for longer procedures. I haven't seen the tolerance or I've experienced it, so I don't know.
Graham, can I ask you, you would like to add something to dexmedetomidine? I'll introduce you, Graham a bit later, but he's also a big fan of dexmedetomidine and has got a lot of experience. Please, Graham.
So I can maybe answer a bit of Peter's question there. We've been using dexmedetomidine to sedate children who come for just using drugs. Okay, that's better. So we've been using dexmedetomidine to sedate children who come for radiotherapy. And you'll see a bit in my talk just now, but essentially when they come for radiotherapy, they've So they seem to become happier. They're not doing this ongoing general anesthesia. So yeah, we've used it a lot in peds. MRIs we must have done, at Red Cross probably 10,000 now under dexmedetomidine. The exception to the rule would be the general anesthetic. I mean, we've got a nice big fancy anesthetic machine that we bought 10 years ago, but we probably use it once a month, if that. I mean, everything is done with sedation. And in kids, I think it's a very safe drug. The one thing I did want to take on about is the breast respiration. And that's something that we haven't seen at all. Annie van Dijk, some of you may know her, she's a anaesthetist in private practice in Cape Town, was involved in one of the first pharmacokinetic studies of Dex in 1999 at Red Cross. And they found that kids that were sedated with Dex had a slightly raised CO2. But interestingly enough, that degree of raised CO2 really stuff that you see in normal sleep. So I'm a firm believer that Dex doesn't really depress your respiration more than normal sleep would do. And I don't want to make it over now, but that's the one place that I find that we do have problems with Dex. If you put a kid who's got OSA and you put them on their back and you make them go to sleep, they will obstruct. And that's the one thing that I'm going to say, warn you about. OSA and Dex is like making someone sleep on their back.
Anybody else? Yes, please, because
I think I'm going to ask him on behalf of many of us here that do out of hospital installations, and you are expecting the questions, so answer. The questions, would you use it out of hospital?
I think, so my opinion is, if you've got experience with it and you know how it's going to respond when you administer it and you know what to expect and how to manage it, yes, you can. It's safe in out of hospital. But that's what I think. It's safe if you have experience with it and you know how to expect or what to expect from it when you administer it and how to administer it appropriately. So not give like a massive dose. The other thing with dexmedetomidine for, I think, office-based or outside of hospital would be the onset of action. It is quick, but I think propofol would have a much quicker onset of action. So in that sense, maybe dexmedetomidine would not be as appropriate for out of hospital. Sorry, you have to speak back.
Just got two questions. I mean, the one thing two things I've got with it is costs, for out of hospital and recovery time. So if you want to, obviously go and do another case, we've had problems with like prolonged recovery and obviously costs.
Yeah.
So for a private setting,
Yes.
patients obviously want a cheaper and faster recovery.
Yeah. Did everyone hear that? So cost and prolonged recovery.
Like versus 20.
Yeah. So once again, patient selection. I think there would be a patient or two where that would be preferred because of the properties rather than something like propofol, midazolam, ketamine.
I think the second phase of that is clonidine, and I think we can connect to the clonidine discussion around Dex quite nicely. But I think in the private setting that we've been talking about, clonidine is probably a much better choice to use as a pre-med, and even we're trying to get it intravenous. If anybody can find intravenous clonidine in South Africa, please let me know. But I'm trying to get a company to make it up for us. But clonidine is cost effective, and you've got many of the same benefits that you've discussed with Dex.
Yeah.
can I just say something about what because asked about out of hospital? Are we allowed to use dexmedetomidine? When we talk about outside the hospital, we call this primary care, and in hospital is secondary care. If you read international books and wherever, primary care outside, but are we allowed to use dexmedetomidine out of hospital? Anybody? Grant, where are you?
Yeah, Prof, I understand that the SASA guidelines say it's an advanced technique. I disagree. I think it is such a safe drug. My feeling is, and I think what we need to do is maybe revise that little aspect of the SASA guideline, but I think that it's such a safe drug that it is probably one of the better agents used, costs aside, but outside of the hospital. I mean, it is the one drug that I'm happy to with our radiotherapy kids, that when we finish, we essentially pack up their port or clean up their port. They get them, mom takes them and they leave the hospital, they go straight home, because they can't sleep in the hospital for 35 days. So then these kids I know that are safe in their car seats. It's not like the propofol with the airway loss. These kids maintain their airway and they don't have respiratory depression. And I really, really believe it is one of the safest agents that we have available to us.
Graham, thank you for that. You see, this is now what we like about interaction. Graham is an expert on dexmedetomidine, and I mean, he can say that he's done thousands of those, and he knows that he's safe. But how are we going to prove that to the people that must decide about where we can use it? I was in a seminar with Harvard people about dexmedetomidine, and they were saying something interesting about dexmedetomidine in patients where it didn't find the same. And this was about an 18-year-old child with autism. So what do? They say the way to do it is to give them 3 micrograms per kilogram intramuscular. Now, dexmedetomidine. Now, why I say this in America, I think you can use it outside the hospital. But how are we going to change this, Graham? I do not really know. You've got so much experience that you can say it, but I don't think there's anybody sitting here with that sort of experience. But thank you for that. It's a safe drug. You hear what Graham is saying. I think, yes, Graham, please.
Something onto it. At some stage, we got overwhelmed with requests for sedation, and one of them was for auditory brain stem reflex testing, which is, so at some stage we got overwhelmed with requests for ADRs, auditory brain stem reflex testing, and we just didn't have the capacity. And so what I did is we had a very, very good pain sister, and I taught her to use DEX. Okay. This was obviously in the hospital outpatient setting, so she would go off to outpatients, she would see the child, she would phone me back, we'd agree on a dose, she would administer it, and the kid would go home afterwards. And I mean, that is how safe I really think it is. I wouldn't do it with benzo, I wouldn't do it with propofol without having seen the child. But it is that safe that we can allow our allied staff to use it. I think we need to get away from this mindset. If you look at how drugs like chloral hydrate are used by everyone. Everyone's used chloral hydrate. That in my mind is a less safe drug than DEX. So I don't know how we're going to change the mindset. It's difficult. But I think the one thing that doesn't help is having a SARS go out and say this is an advanced technique. And I mean, recently in the exams we also had candidates saying that they wouldn't be using DEX outside of theatres because it's an advanced technique. So the message of an advanced technique is being promulgated, and maybe we need to start saying to people, hang on a second, this is safe.
Thanks, Graham. I think I've got seen the hand there at the back.
I would just like to,
please.
I would just like to, if you could tell us more about the amnesic properties of dexmedetomidine.
So, it's with those central alpha-2 receptors. I can't remember the exact mechanism pharmacologically on the receptors, but it's got to do with those central alpha-2 receptors.
Is it similar to midazolam?
No, it's not the same. It's still amnesic, but I know with midazolam it's got you've got both anti and retrograde amnesia, but I'm not 100. I'll have to explore a bit more on that. No. Thanks.
I just wanted to ask, have you ever tried to reverse the effect with naloxone?
No, I've never tried that.
Because sometimes what happens is I use clonidine in the kidneys a lot, and now you've got a very short procedure, 5 minutes to extractions, and your child is drowsy afterwards. If you give some naloxone, it reverses the effect very quickly. In a child who didn't have opiates.
Yes.
Yes, Barbara, please.
Just 2 points I'd like to make, that there is now a genetic dexmedetomidine at half the cost. And the second thing is,
Guys, sorry, please use the mic, otherwise we can't record the questions and the answers for the people online.
okay.
Keep it close.
Just the 2 points I wanted to make, that there is a genetic dexmedetomidine available at the moment at half the cost. And the second thing is I have used it intranasally in children with the MAD device, and it works exceptionally well.
It works really well intranasally, especially with the children. That's either IV or intranasal we do for MRIs for the children. Yeah, it works really well. It's got a bit of a longer onset of action, but the effect of the sedation is the same as with the intravenous. Yeah. No other questions? I think our time might be up. Thank you.
Thank you very much, Nadia. We're looking forward to your lecture this afternoon. I think we had a nice get together this morning, a lot of interactive questions, and this is the way that we would like it. Tomorrow we're going to do it more interactive, so not many lectures, but a lot of discussion. And I think it will be extremely nice. Thank you very much for the speakers this morning, Nadia. I said we were going to have tea by about 10:30, so you see you can trust me with the time. It's about 10:30. It gives you a long time to get into the coffee. Thank you very much.
Guys, can I just quickly, the CPD points, please, if you didn't sign it, you're not going to get it. I'm dependent on that form. If you didn't sign it, you're not going to get it. Don't come and cry. And then anybody that hasn't registered or taken their names on the front, please let me know. And make sure that you get your name tag. Please respond, connect with one another, get your name on the WhatsApp group, and become part of our social community. Thank you.